Thanks very much, Elaine, for that kind introduction and for the invitation to be part of this workshop. It's really exciting to be able to share with you some of the work that we have been doing evaluating cabotegravir, injectable cabotegravir for HIV prevention in pregnant women, but also I will give at least one slide to neonates. Okay. So I think it's important to recognize that in regions of the world where the HIV burden is highest, women bear a disproportionate burden of HIV. And these are also regions where the total fertility rate is high, as much as 4 births per woman in sub-Saharan Africa, highlighting the importance of attending really to HIV prevention in pregnant women. Pregnancy has also been shown to be associated with an increased risk of HIV acquisition, and this is both for biological as well as behavioral reasons that may increase susceptibility, particularly in the last trimester. And I think it's also important to remember that many of the causes or many of the reasons for recent neonatal infections have to do with acquisition of HIV during the breastfeeding period by the mother, highlighting the importance really of prevention interventions for women, both in the pregnancy and lactation period. And this really led to WHO in 2017 issuing particular guidance around the use of PrEP in pregnant and breastfeeding people. So one new agent for pre-exposure prophylaxis is cabotegravir. It's an integrase inhibitor, and it's an analog of dolutegravir, which, as you will see, is an important component of the cabotegravir story. But it's not the same, and it has a high genetic barrier to resistance, and because of its particular physicochemical properties, it can, where it's nanomilled and injected as a depot suspension, it can be dosed every 1 to 2 months, depending on whether you're using it for treatment or prevention. But an important thing to remember is that the terminal apparent half-life is quite prolonged, and this means that even if a woman were pregnant and were to desire conception and interrupt long-acting antiretroviral therapy with cabotegravir, likely there would still be exposure as much as a year after she had stopped therapy. So I want to tell you a little bit about HPTN-084, which was the phase 3 trial that evaluated cabotegravir for PrEP in individuals assigned female at birth who were predominantly cis women. And to remind you of the key features, which is that it was an active control trial comparing cabotegravir to oral TDF-FTC, which is considered the standard of care for PrEP. And there were 3 steps in the blinded period of the trial that included an oral lead-in, and this was really to establish tolerability, because once you give an injection, it's difficult to reverse that injection. Followed by an injection phase, which is 2 injections 4 weeks apart as a loading dose, and then injections 8 weekly. And participants, when they received their injections, prior to injections, they would have HIV testing and also pregnancy testing in the 083 trial. And when pregnancy was detected, injections were, or blinded study product was withheld, and women were then transitioned to open label TDF-FTC. And these were the results. In fact, these are the updated results that were presented at IAS last year, but really recapitulate the initial results, which led to the premature discontinuation of the blinded phase. The DSMB recommended that participants be unblinded and offered the opportunity for access to open label cabotegravir. And this is because of the very impressive results that they saw with nearly 90% 90% reduction in HIV infection in the cabotegravir group. Also, just to say that cabotegravir was well tolerated by participants, and really the only difference in adverse events relates to injection site reactions, which were more frequent in the cabotegravir group, but really kind of very few grade 2 injection site reactions, and most of the pain is experienced with the first injection and dissipates over subsequent injections. So on the basis of this data and also data from a sibling trial, HPTN-083, in cisgender men and transgender women who have sex with men, the FDA approved cabotegravir for PrEP in 2021, and since then it's been approved in several countries in sub-Saharan Africa. And I think what's important really for this discussion is that the package inserts that I viewed really have noted that there's limited data on pregnancy and lactation, but they don't contraindicate use in pregnancy or lactation, and really kind of articulate the need for a risk-benefit discussion with potential users. And I think the important point to make here is that that risk-benefit discussion might be different in different parts of the world, and people may value outcomes differently based on their frequency. And it's really important that we have data that we can give the most comprehensive information to potential cabotegravir users about the potential risks and benefits. Just to outline that WHO have also issued permissive guidance on the use of cabotegravir during pregnancy. But really, there's a strong feeling that there is a need for additional data to really fully, I think, inform potential users about the risks and benefits associated with cabotegravir. And I think in part this is because of the lingering concerns that were raised sort of with the early safety signal around dolutegravir. Even though this was not subsequently realized, it's sort of meant that there's work to be done to reassure people about cabotegravir. So what can we say about what we know about cabotegravir? And I think the answer is that we have some data and it's evolving, but I'll walk you through really what we have learned both from preclinical studies as well as clinical data. So in terms of preclinical data, studies were done in rats and rabbits, and there's no evidence of drug-related fetal toxicity and also no evidence to support fetal malformations. There was an interesting signal in the pre- and postnatal development studies in rats that suggested that there might be premature onset of parturition and increased stillbirths, but this was at very high doses, which are much higher than what would be sort of used in humans, and these effects were not observed in lower doses. And there is a question about the clinical relevance in humans. The other thing that we know is that there is placental transfer. We've seen that in rats, but also more recently an ex vivo perfusion model has showed placental transfer, but the ratio of maternal to fetal cabotegravir is low, and it's considered lower than what we would see for dolutegravir. And so it's thought that this may be helpful in terms of reducing potential toxicities. And then in terms of lactation, we really have very few data, but we know that when CAB was administered to rats, CAB was detected in the milk and in the plasma of nursing pups, and there don't appear to be any effects on offspring growth or development. So what do we know from treatment? This is a recent publication from sort of all the accumulated data from phase 1, 2, and 3 trials that ViiV Healthcare have conducted. You'll see the number of exposed pregnancies is 25, so this is not a big data set. Really, I think there is not many conclusions that we can draw in terms of outcomes, but what is important, I think, is that as with many of the trials at the time, rilpivirine was discontinued at the time of first pregnancy detection, and participants were switched to alternative ART regimens. And so what we can see are the sort of declines in CAB and rilpivirine, these are the CAB concentrations over the duration of pregnancy. And what you can see is that there is exposure to drug throughout pregnancy, even with switching of a regimen, highlighting this point that these long-acting agents stick around for a long time and are going to be influential on pregnancy, whether or not you kind of interrupt treatment. So what I want to talk you through now is a series of data that we've accumulated in the PrEP trial, and I kind of think it's useful to see it in these 3 stages, because what we are able to say more sort of as time has progressed. So essentially, the blinded period of the trial ended in November 2020. There was then a period where participants were unblinded, and while a protocol amendment for open label access was prepared, they remained unblinded and randomized. And then participants have now transitioned to the open label extension, where there have been changes like the requirement to use long-acting reversible contraception was relaxed, and they have the option to consent to active dosing of cabotegravir during pregnancy. So we have a lot of data in people who stopped cabotegravir at the time of first pregnancy detection, and the groups are randomized, and we can make comparisons between the 2 groups. And now, as we move into the open label extension, that randomization has been removed, but we have many people now accepting cabotegravir, and we have people accepting active dosing, and we can begin to learn a lot more about cabotegravir use during pregnancy and in the postpartum period. So I think I ran through the procedures that we used in the blinded trial, really just to say that we had very strict contraceptive requirements after the dolutegravir safety signal. Participants were tested at each visit. As I mentioned, they were put on product hold. We also had a step to confirm pregnancy and to unblind participants for confirmed pregnancies. And what I will do is focus on those confirmed pregnancies and some of the data we present. And then participants were followed up on TDF-FTC quarterly throughout their pregnancy, and then the infants were assessed at delivery and again at 12 months. So this is a table that really reflects on maternal safety and what we know about maternal safety. Just to remind you, this is women who received CAB up until the time of pregnancy diagnosis. The median gestational age at pregnancy detection was 7 weeks, so many developmental processes had already taken place. Most of the pregnancies were detected in step 2, which was when people were receiving injections, and they had had a median of 6 injections prior to pregnancy. And the table really summarizes that there are no apparent differences in grade 2 adverse events overall, and then here are the kind of adverse events in the system organ class associated with pregnancy, but nothing that really strikes you, although kind of the point is that the data set is quite small at this point. There were only 57 pregnancies. And another important point is that we didn't observe differences in maternal weight gain, which has been a concern with INSTIs and also influential in terms of potentially metabolism of cabotegravir. So in terms of pregnancy outcomes, at this stage in the blinded period, we had 57 pregnancies, and there were no real differences between the 2 groups, also no congenital anomalies, and about 8 out of 10 of these pregnancies were assessed in a facility. In terms of infant outcomes, there were no obvious or substantive differences in the sort of means of weight, length, and head circumference. And when we looked at a composite safety outcome, we also didn't see any substantive differences between the 2 groups. One of the things that we were interested in was the pharmacology of cabotegravir. Again, this is tail phase kinetics, but what we did was basically look at drug concentrations in pregnant women in the blinded period of 084, and then also compared them to non-pregnant women in HPTN 077. And what we showed is, again, the kind of long tail and CAB exposure throughout pregnancy, but in the right-hand panel, the comparison of T apparent half-life between pregnant and non-pregnant women, it looks very similar, and this gave us some reassurance that we wouldn't expect to see a requirement for dose adjustment during pregnancy. So just to say that after the blinded period, we accumulated more pregnancies, and I think it's very striking that once women knew that cabotegravir was effective as PrEP, we saw pregnancy incidence increase by threefold, reflecting, I think, the important work that needs to be done to establish safety and PK during pregnancy, because women will desire pregnancy while being safe from HIV. And here are the updated outcomes. Again, no substantive differences between the two groups. I think there was some interest in the pregnancy loss under 20 weeks, but just to highlight that trying to understand pregnancy loss in our region is challenging, where abortion is criminalized in many settings, and this is just a snip that highlights that this was reported as a spontaneous abortion, but clearly there was an attempt by the participant to terminate that pregnancy. So now I just want to talk to you about the open label extension. This is where participants who were previously randomized to cabotegravir or TDF-FTC have the option to choose one of those agents, and then people who have had prior or current CAB exposure are eligible for a sub-study. And during pregnancy, participants can then choose whether they want to continue active dosing of CAB or switch to Truvada, and they are followed for a period of 1 year postpartum, and there are a number of outcomes that are assessed. So just to say that the key questions for us really are, do we see any differences in the maternal pregnancy and infant outcomes in the CAB exposed versus the non-CAB exposed now that we have active dosing in the open label extension? And importantly, do we need to do dose adjustment during pregnancy? So there have been some models presented that predict that bi-monthly long-acting cabotegravir will likely maintain antiviral efficacy, and that's for treatment. And the data that we had from the blinded period also reassures us, but it's still an important question to answer. And the second question we have is really, what can we say about infant exposure to CAB during lactation? And that's because the data is limited, but we have used data from dolutegravir to make assumptions, but these really need to be verified. And also just to point out that there are additional complicated virology questions, because if a woman were to become HIV infected on cabotegravir, and if the infant were to acquire HIV infection from her, and if the infant were exposed to CAB during breastfeeding, what does that mean in terms of resistance? So we think this is rare, but these are also cases that we will document if they arise. So in terms of where we are, we have accumulated 268 pregnancies during the open label extension. I will say that we have gone from a pregnancy incidence of 1% in the blinded trial to about 11% at this point. And about nearly 80% of those who are eligible for the sub-study have actually consented. These are both people who were pregnant at the time we transitioned to the open label extension, as well as those people who chose their product and subsequently became pregnant. And our sense is that the acceptance of cabotegravir in incident pregnancies is similar to the overall trial population, and data will be presented at the conference on product choice. And there's also a poster on women's preferences for injectable PrEP during pregnancy. We've had 44 participants who've had at least one postpartum visit, so we anticipate that we'll be able to say something about dosing during pregnancy within the next 6 to 12 months, but it may take longer for us to accumulate data on the infants. Just to point out that there is no expectation that trials are going to be able to answer questions about rare outcomes, and we really need post-licensure surveillance. Ideally, those surveillance systems need to include a non-exposed group to avoid negative interpretation of results that would be uncontrolled. It's also really important that we develop consensus around what the important safety outcomes are, and that we have adequate sample sizes really to exclude concerns about those safety outcomes. And there is an initiative led by WHO really to harmonize endpoints across implementation studies in order to maximize the ability to report on the safety of cabotegravir in as rapid a timeline as possible. So what can I tell you about cabotegravir for neonates? I think in summary, there's a lot of interest in long-acting extended delivery formulations for neonates, especially given the challenges with oral dosing, and particularly in preterm and very small infants. The advantages of long-acting extended delivery agents is that you can give small volumes, and so kind of costs are a lot lower than adult doses. You could use them both for a treatment and a prophylaxis indication, and maybe easier to implement. The challenges really relate to the dynamic growth of infants. So, in adults, we know that absorption is influenced by BMI to some extent, and the kind of rapid change in weight and growth in infants really makes it challenging to think about how to calibrate dosing and also what that might mean for PK. And there's also, we don't know whether kind of neonates will sort of absorb or release from the depot at the same rate as adults. There is also the additional issue of whether kind of injection site pain is going to be a disincentive for use. But I think in the end, studies are being developed. With respect to cabotegravir, they've been taking a very traditional approach of sort of doing an age de-escalation studies, and there are a number of studies being conducted by Impact. There are also some planned, but none of them are yet kind of at the in the sort of neonate age group. So there is a lot of work to be done, but it's a promising set of ideas for a number of reasons. So really just to round up and summarize that cabotegravir, injectable cabotegravir is effective and well tolerated as PrEP in cisgender women. The initial evidence from participants who had CAB exposure up until the time of pregnancy diagnosis shows that residual CAB is generally well tolerated throughout pregnancy. There are residual exposures throughout the entire period of pregnancy, and reassuringly, drug concentrations appear comparable in pregnant and non-pregnant women, but more work needs to be done. And no congenital anomalies were observed, but the sample size is really too small to exclude rare events. We are looking forward to, in the open label extension, to being able to generate new data on the safety and pharmacology of cabotegravir with active dosing during pregnancy and lactation. And I think it's exciting as cabotegravir is introduced in implementation studies in the region that we look to opportunities for post-licensure surveillance, but we do need to have robust systems of active surveillance with good comparators to be able to draw firm conclusions and not create concern about a new agent. And cabotegravir for neonates has the potential for both treatment and prophylaxis, but really we're in the early stages, I think, of investigating these prospects. So really just want to acknowledge all the contributors to this work, but also the WHO Pregnancy and Breastfeeding Therapeutics Working Group, which has really sort of been leading the charge to accelerate access to antiretrovirals for pregnant and lactating people. Thank you very much.